at this time.
I'm sorry, Chief Cook, can you please repeat that? I had not hit record yet, so please repeat that.
Well, it's perfect timing. Before we begin the session, I've been asked to let you know that the session is being recorded now, and that if you do not consent to being recorded, you're asked to drop off the session at this time. As is customary, we'll start this meeting with an opening prayer. Sagoyedizo, Yehoito Yongets Wakatahiuni. Sagoyedizo, Creator, Creation, we are grateful for this day and all that is provided for us, this very breath of life. We humbly ask for blessings for each and every one of us gathered here today. We extend our heartfelt appreciation to each other for the opportunity to put our minds together, to ponder our people's reality, and to work towards the vision we see for our families, communities, and nations. We ask for wisdom, guidance, and clarity of mind today and all days. Thank you. During this session, we will be discussing the issues of health equity in Indian country. This is an especially timely issue given the current circumstances. The COVID-19 pandemic has shined a spotlight on many longstanding issues that our people face and the difficulties that we face in addressing them. As we will discuss in this session, understanding how to approach addressing health equity in Indian country requires a nuanced understanding of the unique history and circumstances of American Indian and Alaska Native people. We have been subjected to centuries of colonization, where we have seen our land stolen and our cultures and traditions imperiled by the dominant society. During today's session, there will be a focus on understanding health equity through the Indigenous lens. To give you more information, I'm going to turn the floor over to Chairman Larry Wright, Great Plains representative to the National Indian Health Board.
Thank you, Chief Cook. As Chief Cook said, I'm going to give you a brief overview of today's session. You will start by hearing from Dr. Donald Warren from the University of North Dakota, Dr. Betty Jacobs from Georgetown University, and Stacy Boland, CEO of the National Indian Health Board. They will start us off with a brief presentation on health equity through the Indigenous lens, and then they will turn the floor over to you, the participants. You will enter into breakout rooms where you will be asked to discuss spiritual health equity, mental health equity, physical health equity, and emotional health equity. After your breakout sessions, you'll be asked to come back to the bigger room where you will share what your group discussed. We appreciate your engagement on this topic, and we look forward to a fruitful discussion. And with that, I'll turn it over to Dr. Donald Warren.
Hello, thank you and welcome to all my relations here today. I'm very honored to be a part of these important discussions as we talk about health equity and looking at this through an Indigenous lens. And I think it's important for us to acknowledge that we've always had a focus and we've placed importance on being equitable in our communities. Unfortunately, we don't see that in our current health system. So over the next 10 minutes or so, I'll just be talking about health equity through an Indigenous lens, looking at equity versus equality, but also what we can do through academic programs and academic institutions. And as was mentioned, I'm Associate Dean at the School of Medicine and Health Sciences here at the University of North Dakota, and also serve as Director of the Indigenous Medicine and Chair of the Department of Indigenous Health. So we've always had an understanding of health and health equity, and understanding the need to work upstream to focus on prevention and health promotion. And as many of you know, there's a traditional story from this region of three sisters walking along a river. And as they're walking along the river, they see babies and young children in the water struggling to stay afloat. So the first sister declares that this is an emergency, it's a crisis, we need to get the babies out of the water right now. And the second sister thinks about that and says, no, we need to teach the babies how to swim so they can survive while they're in the water. And the third sister keeps walking upstream, and the other two ask her where she's going. Why aren't you helping us? And she says, I'm going to find out who's putting these babies in the water, and I'm going to stop them. And that really is public health. And that's looking at primary prevention. And when we think about primary prevention and health equity in our communities, we have to recognize that our unique history in this nation leads to a lot of health inequities and disparities and challenges. But even more importantly, we also have to acknowledge that even though we've had a lot of loss, our populations are very resilient and very strong. And for us, focusing on health equity means acknowledging the past, but not being stuck there, and recognizing that the strength of who we are as Indigenous people is the solution to promoting our health. And we've had a lot of trauma, obviously, over the decades and centuries. And when we say the word trauma, if we were talking to physicians at an emergency room, they would think of physical trauma, right? And now when we talk about trauma, there's a lot of focus on the idea of psychological trauma and emotional trauma. And I would say that for us as Indigenous people, we also have to recognize that there's been a lot of spiritual trauma. What's happened to our land and sacred places, what's happened to our culture and ceremonies, even what's happened to our children at boarding school, that's a much deeper rooted trauma, which also requires a much more comprehensive and culturally based approach. And when I look at the ways to address healing and recovering from trauma, we have to recognize that we need that holistic approach in terms of spiritual health and prayer and reconnection to our ancestry and our cultures and our language and our sacred spaces. But also in the mental realm, we had our own forms of meditation, and there's a lot of cognitive behavioral therapy that is actually consistent with traditional medicine principles. We also know that physical activity is vitally important to mental health, not just physical health. And then in the emotional realm, having those social connections and counseling is so important. And that we used to focus on social connectedness. In Lakota, we say mitakwe oyasi, which means we are all related. And I think one of our challenges during the pandemic is the idea of social distancing, and social isolation is not good for our health, no matter what our cultural background is. So we have to have a much more holistic approach to achieving equity. And I'm sure many of you have seen this diagram before. It looks at the difference between equality and equity. And I think we take an equality approach to much of our healthcare, much of our education. And if we think of the package of services that these men are standing on, we could think of that as basically a Medicaid plan in a state. One size fits all. Everyone gets the same services, whether or not they are effective. Or even thinking about a medical curriculum. Everyone gets the exact same curriculum, even if it doesn't meet the needs of Indigenous people or other marginalized populations. So we've taken an equality approach, but when we think of equity, we're also looking at outcomes, not just the process of providing services, but we want equitable outcomes. And we can see in this diagram for that package of services, the guy on the left didn't need it. It's serving the one in the middle pretty well, and the guy on the right is still underserved. So we have to be more intelligent and flexible in our programming, whether we're talking about health or education. And I really like this image a lot. And the question is, why is that fence there in the first place? Is our work just focused on overcoming the barriers, or do we need to just break down the barriers? And I really love this imagery that it's not just about the package of services to overcome the barriers. We need to look at those systemic barriers. And part of that I would put forth is the lack of representation we have as Indigenous peoples in higher education and in healthcare leadership positions. I also want to acknowledge Abigail Echohawk. She shows this image, but then she also asks the question, why is it a baseball game, right? Couldn't it be a powwow? Couldn't it be something more culturally relevant? And also recognizing that we don't have to just be observers, we can participate. So this can be taken to a much higher level to understand these differences. So in terms of what we're doing in the academic arena, UND, as many of you know, we've had Indians into Medicine, or the InMed program, since 1973. We've now graduated over 260 physicians out of InMed program and over 500 other health professionals. And we'll be having our 50-year anniversary in a couple of years. So InMed is one approach to trying to break down the systemic barrier of lack of representation. But we also have to have culturally relevant prevention programs and health promotion. So we have an Indigenous Health Master Public Health, and last year we started the very first Indigenous Health PhD program. I'm very happy to say that in our first 2 cohorts of the PhD program, we have 34 students, and 29 of the 34 students are Indigenous people. So we have 29 Indigenous doctoral students just in our PhD program, plus 20 or so medical students, just right here at this relatively small School of Medicine and Health Sciences. So these are things that can be done if we choose to. Also, if we think about other areas of need, we need to have more appropriate research. So we do have a recently funded Indigenous Trauma and Resilience Research Center, where we're not just looking at trauma, we're also looking at resilience and cultural factors that provide safety in terms of health promotion. So in terms of our Indians into Medicine program, I've been very pleased with the outcomes. You know, we have a lot of very good support in terms of the institution working with us and graduating students. But we also have to look at this framework of a medicine wheel for student support. And spiritually, mentally, physically, and emotionally, what we're doing is providing cultural support to the students in the spiritual realm, academic support in the mental realm, financial support in the physical realm, and social support in the emotional realm. And recognizing that we have to have much more holistic approach if we're going to have education equity. So in our discussions in the breakouts, we can look at spiritual health, mental health, physical health, and emotional health through an Indigenous lens, talking about equity. Just very briefly on our PhD program, we really want our students to develop skill sets and competencies and research and evaluation and policy, but it really is to start to improve our outcomes at a higher level and making sure that the research questions being asked are being asked by people who actually have lived experience and understand the issues in a much more comprehensive way. Also very proud of the Indigenous health scholars we've been able to bring together at UND. Just so pleased with the group. In addition to myself, we have Dr. Allison Kelleher, who is Koyukon Athabaskan from Alaska. Dr. Melanie Nadu, who is Ojibwe from Turtle Mountain. She has a PhD and MPH from the University of Minnesota, focused on epidemiology. Dr. Nicole Redbers, who is Dene Nukwe from the Northern Territories of Canada. She's a naturopathic physician with an MPH from Dartmouth. Dr. Ursula Runningbear, who is Shichangu Lakota from Rosebud, South Dakota. She has her PhD in clinical science and a master's degree in sociology. And one of our newest hires, Dr. Kyle Hill, who's Ojibwe, Dakota, and Lakota. He has his PhD in clinical psychology and a master of public health from Johns Hopkins. And we're hiring several more faculty as we speak. And I think one of the areas that we need to focus on is educational leadership. We have to have more faculty members and more higher education administrators to bring the students to our programs and to try to improve those outcomes from that perspective. All right, very pleased to announce we just established a brand new Department of Indigenous Health. So new it's not even yet on our website, but we're the first medical school in the world to have a Department of Indigenous Health. We're bringing together our research programs, education and service programs, and development opportunities to try to make sure that as we move forward, we're doing the right things for our people. Our longtime InMed Tribal Advisory Board chairman was Dr. David Gipp, and we unfortunately lost him a little over a year ago. He's made his journey, but we do have an endowed scholarship in his name for our medical students. It's remarkable to me when we're talking about equity. We shouldn't have any of our kids getting $200,000 in debt to go to medical school. In this day and age, we should be funding their medical education if that's what they're choosing to do. So part of our focus on equity is in his name, Dr. David Gipp, to try to promote more equitable outcomes and access to higher education, specifically medical school. All right, I know that's at my 10 minutes, so there's a lot of information very quickly, but again, so pleased to be a part of these important discussions, and I can hand it off to Dr. Betty Jacobs.
Thank you, John. That was a wealth of information, and I hope I can be as substantive and talk as fast as you did. I think this is a very critical topic. Those of you who have joined us to discuss health equity must be motivated by the alarm and concern we have with health disparities. The concern about illness and prevention has been long-standing for people to be functional and in their best health possible. but the shocking part is that as we compare what we have to give in terms of best practices or resources, it is a lack of justice that our American Indians, Alaska Natives are not on par with outcomes, but also the allocation of resources. Today, I'd like to talk particularly, as Don so eloquently set the stage, about some pathways out. In order to get resources, we do need very good data to document disparities, but that puts us into the general culture, particularly of policy and allocations, which is a very linear process. And as we saw with the 4 pillars in their presentation, this is a parallel to our cultural continuity. And cultural continuity is about engaging the traditions, keeping alive those things that have helped us to be resilient, as well as to revitalize those things that have dropped behind and are sometimes reasons that disparities exist. And I think as we look at that medicine wheel, the fact that categories of resource commonly do fit into the physical, mental, and fortunately we've looked at emotional well-being, but the spiritual well-being is one of those forces of tradition and understanding that can complement this cultural continuity. We do have conditions that have been mentioned about crowding, injuries, poverty, the poor resource allocation, bad roads, not such good cars, weapons, substances that disrupt families. Those are very much a concern in our origins. And we spend a fair amount of time talking about that. And with just 10 minutes today, I wanted to take a look at these 4 pillars, the strength of our being as an anchor for today's discussion, and to consider that in our interaction with health systems, that it does map on to a very linear process. And while we look at cultural continuity, we often look at our ancestors and long-term traditions, but the kinds of things that have enabled the past 50 years of progress, which is insufficient, but is also creates a tension. As I am involved with young people who are choosing medical school, who are doing their undergraduate choices, I remember my own time of frustration with older generation. And among the many wonderful advocacy organizations and programs that have helped create a cadre of clinicians, some of whose pictures we just saw from the University of North Dakota, people enabled some of that growth through a variety of legislation activities, such as the Indian Self-Determination Act, the maturity of Indian Health Service beyond just building hospitals and clinic, but to look at staffing and service. And organizations such as one I was involved in as a student, the Society for Advancement of Native Americans and Chicanos into Science. One of the issues that was a tension as I joined this group and the leaders were charting new direction was whether or not you respond to the urgency of circumstances and situations just to get services out or shortcut or propel faster the things that are needed, or if you hold on to the strengths of culture, knowing that they can sustain you and doing the long-term investment of what it takes to become a scholar or a clinician. It's a long time of growing skills and credentials. And while this is far below what we would want it to be, at one time, it was much more difficult. I think someone needs to mute the interference. Thank you. The ability to have leaders who can advocate from within, and this investment of young people is so important. I'd like to comment on some of the things we saw as an example, many of us have experienced, and that is while we have problems of diabetes, mental health, or substance abuse problems within our communities, the response to building these programs to very complex problems. These involve not only the physical, but also mental, emotional, spiritual, and the families and communities. The model programs that have been done for several tribes is terrifically important. And I concur very much about looking at resilience. I am at Georgetown University. I've been here for some time and co-founded the ONeal Institute for Health Law. And these policy recommendations, I think, are useful to look at some of these things from the clinical standpoint, and those system issues that undergird what allows this. At the heart, I would say that one of the things that has been positive in the system approach has been the law, regulation, and policy related to self-determination, but also the fact that we hear those principles recited again and again. As I worked with the UN framework for Indigenous peoples, some people consider this a slogan and not understandable. I think as we experienced the COVID pandemic in many of our communities, we saw the ravages and risk that is apparent when you have an agent such as the COVID virus introduced into a community where housing is inadequate, where services are distant, or formidable. That sense of trust in services is one that many people have labored hard to assure fits. But as that ravage occurred and vaccines were available, tribal leaders were very involved in the distribution of vaccines and making their own plans within their communities. They also had the powers of self-governance for border control and community support. Those features, I think, are commonly mentioned, and I'd like to bring those to consideration for our breakout groups. That self-determination, self-governance, where the intrusion of programs, sometimes with different intentions or perhaps goodwill, but not good understanding of our communities, are controlled and governed through our tribal governments. Another feature that I would suggest for discussion is the same term that Don happened to use, this goodness of fit for programs and for resources. Actually, the best program support in general is not always the streams of focus on diabetes or maternal child health. It is less restricted so that people with good judgment, experience, and skills can guide it to be where it's needed most. That very useful picture of people standing, looking at a game, that people need different supports under different circumstances and sometimes at different times. I also would suggest that cultural competence is certainly something that others can learn and bring, but there is nothing like having people of American Indian, Alaska Native life experience to be part of the core community of providing services, and also the interface advocacy and writing of programs, regulations, and policies. Coalitions that we're often involved with, whether they be federal, regional, or with sponsors, is terrifically important. And something that I encounter when I see some of you at other places is that whatever our job descriptions may be, there is an attitude of mentoring. Sometimes that is a formal process and we sign up to be a mentor, but many times you have late night after dinner conversations or coffee with someone that is part of going above and beyond to make that next generation stronger and better able to carry the attention to the spiritual, mental, physical, and emotional well-being of people in order to promote health equity. So as we consider the disparities that have been documented through a number of citations, most of which we are familiar with, and we continue to promote good data collection and good data analysis. But our idea of cultural continuity, which is very much in that circular intergenerational part of life, does map on to interfacing with these systems of policy, regulation, and resource allocation that is very linear. And so that interface requires a skill set that can live in those two worlds. I'm very pleased that I got to participate today, and will be able to join one of the breakout sessions to discuss this further, and join you all once again when we come together. So from this point, I'd like to pass this over to Stacy for the last presentation.
Thank you, Miigwech, Ani, Kwe. Good afternoon. My native name is Turtle Woman. I am a citizen of the Sault Ste. Marie tribe of Chippewa Indians, and I'm the Chief Executive Officer, also known as the Executive Director of the National Indian Health Board. I'm really pleased to be with you today, and I want to thank both Dr. Warren and Dr. Jacobs for sharing their time, their knowledge, and expertise with us in this space today as well. I'm going to talk for 7 minutes. I'm setting my timer right now. Okay, I'm not setting my timer because it's too complicated for me to do that and this at the same time, but I'm sure that someone will warn me when I've gotten there. When I think about health equity, I think about the very basis of what is the essential challenge for Indigenous people of this continent, if not the whole world. Those who have been colonized, those who have been conquered, or those like some in Brazil that are still in the process of being conquered. The same is true of Southeast Asia. But when Christopher Columbus embarked on his journey to find a nautical eastern passage to Asia on behalf of the monarchy of Spain, 1492, he had no idea that we were here, and he had no idea where he was. But much to the astonishment of Spain and all of Europe, he found this great, rich, amazing landmass that had been occupied and had been home to millions of people, tens of millions of Indigenous people for since time immemorial. And my take on health equity goes back to that moment, because equity ceased the day that Christopher Columbus walked onto these shores. I used to talk about this in terms of the big hand of 1492, that all of us, when we were conceived and placed on this land, when Creator put our feet on these lands, and this is the ground that we're standing on, it was as if Creator had shot arrows into the sky. And the arrows were our peoples, all of us, North and South America, Mesoamerica. And the arc of those arrows was our destiny, and the purpose for which Creator placed us here, the purpose for which Creator decided these are the people of this land. And when Christopher Columbus came along, it was as if a big hand of 1492 swatted those arrows from the sky. And we've been trying to relaunch our destinies and our purpose since that time. Unfortunately, the way that colonizers go about their business is about a lot more than stealing our land and all of the natural resources and wealth that flows from that land. It's basically about our souls. And to that end, on May 4th, 1493, Pope Alexander VI issued a papal bull called an Inter Serrata, which was also known as the doctrine of discovery. And through this was provided the justification for basically stealing our land and killing us. And that was that Christian nations could encroach upon the sovereignty of non-Christian nations by declaring that barbarous nations, this is a quote, be overthrown and brought to the faith itself. The document provided a legal justification for the colonization of the Americas by declaring that the sovereignty of Christian nations supersedes that of non-Christian nations. It also presented a theme that would permeate the relationship between tribal nations and European powers, as well as their successor sovereign, the United States of America. The doctrine provided justification for belief that being non-Christian meant you were also not human. Interesting that when we look at this period in history, that at the same time Christopher Columbus stumbled upon us, others stumbled upon Africa. And included in the doctrine of discovery that we're discussing right now was, by the same rationale, permission and justification for enslaving Black Africans, ripping them from their homes, putting them on ships, and creating an incalculable diaspora for slaves to be provided all over the world. And in this way, I think of us as two gnarly, ancient trees who got planted or supplanted in that soil of the doctrine of discovery. And history has made us, these two gnarled trees, wind up around each other as we grew upward toward the light and had our own different iterations of how history would play out for us. But in both iterations is extreme inequity in health, in everything. Of course, the subject of our discussion today is about American Indians and Alaska Natives, and I'm going to go back to that. When you consider that's the foundational justification for how we came to be in this land, how we came to be considered, I should say, in our own land. And then you move on and you look at all of the policies over time, the boarding school policies, all of the removal from our land, put on reservations, the killing of the buffalo, the removing us from our ability to eat our native foods and speak our native languages, and then ultimately to even not be able to practice our native religions. What that gets at is not just our land, but at our souls. And to me, from my perspective, and one of the pillars that Dr. Warren laid out right away, is that when you practice cultural erasure and you remove our people, you have a 100-year policy just in the boarding schools alone to remove our native language, our cultural identity, our place in community, our concepts of health, and separate us out from that. That's the great healing that needs to take place for us to grab onto what we define as equity, not what mainstream defines, but what we as Native people need to recapture, reinvigorate, reflower our cultural identities and hold on to them with everything that we have to create an equitable future. I have a feeling my time is up. So I'm going to end there just as I hope this stimulates some conversations as we break into our breakout sessions. And with that, I'm going to end. Miigwech, thank you.
Thank you. Thank you for setting the stage with those wonderful presentations. We will now move to the next part of our agenda. In a few moments, you'll all be sorted into breakout rooms and asked to consider health equity from the following perspectives: spiritual health equity and cultural health and the role of ceremony, mental health equity and the role of education and workforce development, physical health equity and role of health systems infrastructure, and emotional health equity and role of social connections. An NIHB staff member will be in your breakout room to help guide discussion and answer any questions that you may have. We ask that each group designate one person to act as a reporter for when we all come back together to share what your group discussed. And with that, we'll move to the breakout rooms.
And everyone should be back together now for everyone to discuss what the separate breakout rooms brought up. Thank you, Chief Cook.
Okay, sure. So thanks for welcoming everyone back. I hope that your discussions, we were just getting going in our group. But we'd like to hear from everyone on how, I think you all have someone selected to report back. So does group one want to report back first?
Hi, Chief Cook. I can report back for group one. So one of the things that we focused heavily on was the role of social media and kind of newer tools to address the pillars. So obviously social media has, the tremendous ability to bring people together. You can connect across space, and especially during the COVID-19 pandemic, it allowed people to stay in touch with people that they could not actually interact with in person, which is, one thing, right? It fosters social connectivity, but it also, especially, it magnifies information, right? So you can share information about upcoming events. You can share information, just general health information, right? Which was really useful during the pandemic. But, so it's a tool that you can use to address the 4 pillars of health equity, but there are obviously limitations, right? To social media. I think that perhaps was obvious when we talked about this was a lot of elders don't use social media. So how do you reach folks who aren't on social media? One person in our group mentioned, they set up newspaper style mailboxes outside of the elders' homes, so they could provide this information on flyers and things like that. So that took care of information dissemination. But we also talked about some of the other limitations, right? For things, this goes into kind of the, actual physical health equity issues, but infrastructure, right? Broadband. That makes it tremendously difficult to disseminate information if you don't have access to reliable broadband. It also, and then you start thinking about telehealth, right? The role of broadband and facilitating that. So that was, and one thing that we discussed too. And one limitation of social media that was brought up too was, in a lot of cases, you can't put traditional ceremonies on social media, right? So that's a limitation. You still need to bring people together to kind of preserve these cultural traditions. So, our discussion, I think, focuses a lot on kind of the role of tech and social media, which is, I think, appropriate today because apparently Facebook is down today. So, but social media is a tool, but it does have limitations. But that was kind of what our discussion focused on.
Thank you.
Chief Cook, I can go for group 3 if you'd like.
Go ahead, Crystal.
Thank you. So group 3 focused on physical health. So we had a really good discussion regarding COVID and the challenges that it posed, getting therapists and providers to actually stay in the rural communities. They're experiencing burnout. And in addition to those challenges, we spoke about the actual COVID vaccine and how there may be some very traditional people that do not want the vaccine. They don't feel comfortable with it. So providing individualized education that can help explain the components of the vaccine and reach out to them where they are instead of shunning them. We also had several other topics come up that were very interesting. Anything from talking about tribal best practices instead of evidence-based best practices within the state structure for preventative services. A good example was sweat houses, the chronic underfunding of IHS that limits healthcare availability, the lack of culturally competent providers, and then that in turn leads to the readily and easily available medical services. Many have to travel further, or they have to travel off the reservations. And then we looked at food sovereignty for tribes and the lack of healthy foods, and they're being far from resources. And then we also looked at certain substances that enter the body, from alcohol to opioids, and needing information, and making sure that community knows the critical components of that. And then we also spoke briefly about traditional tobacco use within the commercial tobacco control efforts. So group 3, thank you for the discussion. I appreciate it. And thank you for the opportunity for me to take notes for you.
Thank you, Crystal. Sarah?
Yeah, I can go for group 2. So our facilitator was Stacy, and we kind of focused on what struck us about the 4 pillars. So we had a lot of great comments, and I'll just kind of run down the list of notes that I've taken. But some folks, they shared about, their success with the Medicaid counter rate, and they felt like the health equity has been achieved, and the fact that they are also, they have cultural relevant services. They were really struck by the InMed program presentation, and really liked how, tribes can also, receive cultural care and talk and focus on cultural knowledge, which is really important. Some folks really appreciated the conversation, including spiritual equity, and that it is important to bring that type of healthcare to the people. And folks shared that they had even some folks with their vast they cover a lot of area for more rural areas, and so they purchase a mobile clinic and are looking at more telehealth and telemedicine. And for another person, they also talked about having their own data sovereignty, which continues to help them move how they see their own information, and important for them in order to advocate, and I think it's important to advocate for their own policies and which influence the laws being given. Others talked about representation for Native staff, professors, and how that affects college students, and that is important to the mental, social health needs of college students. Folks talked about looking at coding and their ways of trying to be able to match up traditional services, which were kind of being looked at as more medical. And so they really the opportunity to be able to dig in deeper and look at that data was really important to them in trying to influence long-term health equity. And also another person talked about just looking at traditional ways of I know Stacey, she talked about looking into the traditional ways of defining health, which is the health of us all, the mind, body, and spirit, and that traditional ways of healing is important. We had another person that talked about colonization in response to that trauma. It still exists today in the US, and in these folks, we have to, I guess, look at the ways in which we see basic needs, and how there's folks with without water, and people don't have what they need to be successful, and that the per capita inequity among AINA versus their counterparts are is very it's a wide gap. And then they also noted that telehealth is super important. And another talked about we have to also look at the environmental impacts, which intersect with health equity. And they talked about in their area, the river was when it was really sick, it impacted like the salmon, and how that also in turn impacts, the people and their ways of living, and also being able to teach about, the salmon. And then I really like the last comment was also, and how all of these pillars are connected, and we can't treat one thing without all of them, and that is why infrastructure needs are critical. And so I really appreciate our group's comment. Sorry for taking so long, but I just really wanted to share everything that everybody said.
That's great. Thank you, Sarah.
Yeah, I can go ahead and, I know we're getting a little short on time, but I'd love to present on what we talked about in group 4. So it was wonderful. We had people from Dene Nation and Apache and Cherokee, people from IHS, tribal programs, and academics. It was wonderful discussions. I really appreciated that. Some of the common themes, one is that we need to have safe places to integrate culture and to develop programs in our communities, and recognizing that the current health system doesn't always create safe places where we can express our thoughts and ideas from a cultural perspective, and that needs to be incorporated into an equity focus for us as Indigenous people. And then also we need to be able to incorporate spirituality into health and wellness programs, and that, again, that's not something that's always done in the broader health sector, but through an Indigenous lens. It's so important to so many of our people and so many of our cultures, and it can't be excluded from health and wellness. We need to be able to incorporate spirituality in a safe way. One of the individuals from San Carlos, and talking about how they're actually incorporating spirituality and traditional healers into their healthcare system, actually working within the hospital, and that they're doing a better job of identifying and using local herbs and plant medicine, and more of a focus on natural medicine. So there's emerging models out there where this can be done, I think, effectively. Then from another perspective, looking at health equity and treaty rights, if we look at health equity from a broader perspective, there's no other population that can talk about treaty rights to health services, and that needs to be incorporated into any discussion on health equity. And then also related to that, looking at within the federal government, sometimes we're excluded from discussions because the belief is, well, you already have Indian Health Service, therefore you don't need to be involved in these other discussions. And it's obviously not true. We need to recognize that, yes, we are a political designation as enrolled tribal members of federally recognized tribes, but we are also a racial population, racial minority population. We should have seats at all of those tables and be included in all of those discussions. There's also a discussion about the idea of health equity offices and what might be the benefit of a tribal health equity office, because there's so many things going on at the federal level, the state level, and the private sector at the tribal level, but they're rarely brought together, that we see a lot of silos. And perhaps a role for a tribal health equity officer is to identify all of those programs and bring them together, because we would bet that probably there's nobody who knows all of the programs that are going on. There's also discussion for the need for better data, engaging youth in the programming, and focusing on culture as prevention. And then even some practical policy discussions on equity, that we should have direct funding to tribes, not going through the states, and that with our tribal sovereignty and government to government relationship, that the states shouldn't be the gatekeepers to access for us as tribal nations. And that's got to be a part of the equity discussion as well. So kind of a lot of broad-based discussion, but I really appreciated everyone's input. And again, it was a very diverse group.
And even though we're diverse, we're a lot the same. And I heard that in our group as well. So we want to thank everybody who participated today. And it sounds like the groups were engaged, and we appreciate that. We've come to the end of our time, and I want to thank our speakers very much for joining us, and all of you who shared your thoughts during this session. If Dr. Warren or Stacy, if you have any closing comments to share.
Stacy, please go ahead.
Thank you. Just want to say thank you to Benny Jacobs. Thank you for Don Warren, for Chief Cook, for Chairman Wright for showing leadership and being with us during this time. I want to thank the folks who took notes and spoke up. And Sarah, you did a great job. Good job. And I also wanted to say, this is part of a learning process and part of ongoing work. So what you've done, experienced, shared today, it's part of a beginning. It's not just a moment in time that's frozen here. This is a dynamic process of us all together, shoulder to shoulder, creating equity in our realities as Indigenous people. So Miigwech, thank you for contributing to that process, and there'll be more to come. And I'm going to put my email address in the chat. Please follow up with us. You can contact me anytime if you want to be involved in further work on this through what we're going to be doing at NIHB. So Miigwech, everybody. And my email address is also on our website, www.nhb.org. Thanks, everybody, and hope we see you tomorrow. Have a good evening.
Bye, everyone.